Thank you
Uh,
very much.
Thank you, Professor, for such amazing presentation. You showed us the horizon of reconstruction of the perineum, which you have done in the past. Many of these cases, many of us can still imagine that we will be able to do it or not. So I'm expecting a lot of questions for our presenters.
Yeah,
So,
just to start,
okay.
can I ask? Yeah,
Yeah, yeah,
if
sure, sure. Go
if there are any
ahead.
questions, let them ask. But if none, I can start with.
Let's start with our organizer, Dr. Sachin Chowre from India.
Okay,
Please go ahead.
Sensei, thank you very much for that wonderful. I have been observing this from last 2 years with you, but still, it's amazing cases. That especially the appendix case is. I really want to do one such case in my lifetime because it is really amazing way of bringing the technology as well as
Mm,
the innovative ideas of yours, the Orochi's principle. And because all this penile reconstruction, the problem is post-op, if you use hairy skin anywhere,
yeah.
and especially in our country, we don't see GID much, but we have uh, penile cancers, and where we do radial forearm. So the hairy skin plugs into the urethra, and you
Mm,
really have given a golden way of solving it by using appendix, which is
mm,
just like to like the principle of plastic surgery defined here.
mm.
So it is amazing case, Sensei. I just want to ask, uh, how do you psychologically analyze all these patients? Because obviously GID patients will be analyzed by psychologists, but the post-cancer patients also, I have
Mm,
seen they are in India, they don't come up with reconstruction. It is their spouse who come for reconstructing the penis of the husband. So
mm.
how do you analyze such patients? Because post-op management, a lot of things depends on it. Can you please explain us the psychoanalysis of such patients?
Yeah, this is the little difficult point, but probably all male uh, has proud of the existence of penis. Everybody want to keep the penile shaft, and also GID patients many times teach me why penis is necessary. So GID patients always say this is a symbol of male. Also, rather than the sexual intercourse symbol. Also, all patients say standing urination is symbol of male. So, and also, if possible, sexual intercourse and also sensation. And the young patient want to sensation and also sexual intercourse. But penile cancer many times very old, elder people. So that's why for them, sexual intercourse is not so important. But symbols as a symbol, yeah. Some patients, even 80-year-old, came to me from Okinawa. 80-year-old, but so I asked him why you need a penis, yeah, a shape of penis. So he said, when I die, and everybody, see my naked body, and if I lost a penis, it's a big shame. Everybody see my naked body. So at that time, for this time, yeah, he need a penis. He said so. But I think that not all patients need a penis, but some patients strongly desire to maintain the penile shaft. Also, standing urination. For young male, of course, sexual intercourse are necessary. But GID patient, not all patient, all GID, male to female to male has a partner. Only few, maybe less than 20%. based on my experience, has a partner. So that's why sexual intercourse is not so important. Symbol. And also, public bus. They want to walk in a naked, yeah, body and they want to proud the big penis. That's why other plastic surgeon criticize me. Your penises are too big, so not so good. But GLD patient never think. GLD patient truly thinking the big penis is a big pride. So a feeling of patient and plastic surgeon completely different. Anyway, experience is very important. Also, normal male. Also, even old yeah old old man. Also, if possible, penile shaft is very important.
Yes, sensei.
Just after amputation. But several years later, they give up, probably give up, even in Japan.
Yes.
Completely same as the fingertip amputation. Just after the amputation, everybody want to make fingertip, but several years later, male give up, easily give up. But female,
Mm.
some of the female, even 80-year old, want to get. So it depends on the individual
Mm.
personal thinking. So patient always decide only those patients that come to us.
Yes.
Yeah.
Thank you, sensei. And I wanted to ask one more question. See, whenever we talk about a reconstruction, so aesthetic, form, function. So in this case, you have already shown how the erection can be done by a bone.
Mm.
Then the function, that is the urine passing through a good conduit like an appendix. And
Mm.
I just have seen few of your photos where you have shown that the clitoris is also kept there so that the
Mm.
sensation or sexual sensation also is felt. Do you have
Mm.
any other methods to improve on the sensation part of the uh, reconstructed phallus? That is also
Yeah,
very important to know.
yeah, sensation, skip lab is not so good sensation, recovery. Rather Horam has very nice sensation. Siemens Weinstein show 2 point something, nearly
Mm,
normal.
mm,
So masturbation is possible. But before surgery, everybody want to get sensation. But after surgery, even a skip flap, no one asks the normal sensation of the whole body, whole penis.
mm,
Probably, but everybody say clitoris, female to male. Clitoris is a very important for the masturbation.
mm,
Yeah, so that's why, yeah, 20 years ago, I always think sensory recovery is a very important. But at this stage, I don't think so. Yeah, most important point is large urethra.
mm.
Yeah, radioharm tube in tube is a disaster. Many time obstruction of urethral occurs.
Yes,
So that's why if urethral obstruction occurs, yeah, shape of penis are completely destroyed.
yes,
Contractile urethra occurs. So it's a nonsense. Yeah, destruction occurs. So slender patient, radioharm is very nice, but year by year, adipose atrophy occur and become a very uh, small penis, slender penis. So long-term follow-up is necessary. Also, donor site. I always cover the forearm donor site by ALT flap. So donor site is a disaster. Radial forearm flap. Donor site is if you do a full thickness radial forearm flap. Donor site split thickness is not so good. Also, bone always necessary to maintain the shape of the penis. Also, yeah, too big, yeah, bone. It's disturb the sitting position. Not so long length, but vascularization of bone are always necessary. Free bone or iliac, costal cartilage, it's a nonsense. Absorption occurs. Also, urethra, split thickness or full thickness, it's completely, probably nowadays, no one believe skin graft is enough for urethral reconstruction. No one believe it's a completely lie. I cheated by the previous paper.
Yes,
Thank you,
Sensei.
Professor.
Thank you. Thank you so much.
There is another question from Dr. Fahad. Fahad, go ahead.
Thank you, sir. Professor Koshima, it was a wonderful talk from you. So I'm very glad that we have uh, such a information regarding penile reconstruction. So my question is regarding sunset penile flap. So which one is your favorite flap of choice for sunset reconstruction? And is it going to put a nerve graft in a single stage, which is better procedure, or we have to go for a two-stage procedure for a sensate lab? Please, I would like to hear your answers.
Yeah, Sajin, please, I cannot, hear quite well.
Mansur, you can go ahead and explain, please.
Okay, I would ask on behalf of Dr. Fahad. Uh, Professor, he wants to ask about regarding the sensate penile reconstruction. Which is your flap of choice? And when you want to do single stage sensate flap reconstruction, how will you do it? Would you put a graft?
Oh, Radio Holland. Radio
Yeah.
Holland best, completely. Yeah, Semis Weinstein probably 6 months later become a normal sensation. 2.3 mean almost normal. Penile sensation recovery occurs. But other flap, ALT and also skip, sensation is not so good. Also, I'm doing the split thickness skin graft on the adipose. So that's why even the sensory flap I use, sensory recovery is not so good. But rather horn, skin, superficial skin, sensory recovery is very nice.
And Professor,
Actually,
another part of the question is
young male, rather horn may be better because they can do normal masturbation. But donor site is disaster, so that's why if you do a radial horn reconstruction, you should include bone. Partial bone is essential. Split, radial bone with feeding vessel, bone branch. And also, donor site coverage with flap for young male or young patient, young GID. Donor site coverage with flap is also very important. If you do so, probably the best result. But sometimes, fatty patient, you should not use radial horn flap because stenosis of urethral occurs. Thin patient, it's okay. best result obtained. This is my comment.
And Professor, the continuation of the question is, do you make it sensate in single stage or do you go for two-stage surgery?
Oh, single stage. Two stage it's difficult. Yeah. But if you do hemipulp, sensory hemipulp flap for glans reconstruction with orochi concept combined with LT or skip combined with hemipulp, sensei hemipulp with the orochi concept, probably it's okay. But only glans sensory recovery occurs. Or partial radial forearm flap transfer combination with sensei radial forearm with skip. This may be very nice sensory recovery occurs. So partial those are region, those are aspect of penis and also glans area. Radial forearm sensate flap. And the border side cover with skip flap. This may be a nice sensory recovery occurs. I never do, but probably future young generation in this member. Fahad, you do. You
Yes,
should
thank
do
you.
this
Inshallah,
new
we will
idea.
do.
No, your question, raise my this new idea. Thank you very much.
Thank you,
If
thank you,
I have a
thank you.
chance, I'll do combination with combined flap, sensate flap. This is the best result may occur. I also combine with the appendix. This is probably very nice. So urethra with skip flap. And those are regions covered with the sensate radial forearm. This may be good. Appendix transfer is very, very difficult because appendix actually is only 0.2 millimeters. So you need a nano or real supermicro technique. Little bit dangerous. A nice idea.
Thank you, Professor.
Okay. Yeah.
Sachin, do you have any other question?
Yeah. Thank you, Dr. Mansur. So my question is to anastomose the appendix itself. Yeah. You anastomose to the flap, the rest of the flap. Yeah. Or you find a specific recipient vessel.
Yeah. Your question always. Very important point. Yeah. Always I anastomose to the perforator or radial artery. Committant vein. So it's a very, very enjoyable anastomosis. So I try the dissection of the appendix artery and vein to the proximal region, more big and longer pedicle. It's impossible because appendix vein is fragile, cannot do the dissection. Very, very thin, like thin paper, rupture occurs. So standard appendectomy is only standard appendectomy with a long vascular pedicle dissection impossible. So that's why short pelvic appendix transfer necessary. So receiving the vessel is very important. Probably main trunk or radial artery into side. Probably it doesn't work. Yeah, so perforate of the radial artery 0.5 or 0.2 millimeter is the best candidate of recipient vessel. So this is a very important point. At this stage, probably no one succeed this technique. Yeah, but Hanchi Chen only one succeed appendix transfer for urethral reconstruction, penile urethral reconstruction. He used island appendix transfer. Yeah, yeah. He used yeah oh he used more big vein, big vessel with Kekum. Yeah, uh, mesenteric vessel or island. I forget, but anyway, he succeeded. He didn't anastomose the real appendix surgery. So there is other options. Probably we need not to use appendix surgery. Mesenteric surgery also probably I can use. Or use other intestinal transfer, partial intestinal wall, and make a small tube. So this is other options. So we can use a more big mesenteric vessel.
Thank you, Prof.
Yeah, welcome.
Insert the catheter, whether you need the dilatation of the lumen of the appendix.
Oh yeah. This is also very important. Yeah, appendix is a little bit small. So post-operative dilatation using a bougie is also a very important technique. So if we do urethra produced by skin tube, dilatation using a catheter, bougie, makes erosion and finally contracture and obstruction occurs. But appendix is completely different from skin tube. So dilatation is very easier. Easily dilated without erosion. Actually, I asked the urology to expand the urethra. So urethra become bigger and safe. Yeah. Discharge, several weeks, discharge continue. Incisional discharge continue, but several weeks later, it's completely stop.
So, thank you, Professor, for a nice discussion. And
Yeah.
my question was regarding this mucosal discharges through the when we reconstruct with the appendix. Another related question would be, can the appendix bring its problem with itself when we make urethra out of it? Like the appendix can develop appendicitis, like inflammation and pain and stuff like that. What do you think about that?
Yeah, probably never occurs because distal portion is open.
Professor,
Appendicitis occurs because it's a blind. Distal are
and-
completely occluded, blind. So that's why accumulation of bacteria. Okay,
right.
but distal portions are open, so accumulation of bacteria never occurs. Yeah.
And my other question is based on your experience, such a vast experience. So, what is your preferred technique to reconstruct the urethra? Because we see a lot of dehiscence, urethral dehiscence, and fistula formation. So, whether it is appendix or flap, pre-flap.
Yeah, skin flap is easier. Also, why fistula occurs? Because caliber of urethra is too small. Also, tubing tube. That's why expansion of urethra is impossible. So, make big urethra. Always I put this marker pen within skin tube, and this pen I use, move loosely move. So, but with so flap need maybe 10 centimeter. So this causes never causes stenosis. Yeah, fistula caused by the stenosis. So that's why the design of skin tube, fistula or stenosis never occurs. So that's why I recommend the skin tube is better. Why I use appendix? Because receiver side had very heavy irradiation. Those cases, or if you use skin tube, proximal stenosis always occurs. That's why I use appendix. Appendix, stenosis never occurs, even a heavy irradiated case. So this is absolute indication of appendix. Irradiation causes a serious problem, proximal obstruction. So that's why, but appendix are never, stenosis never occurs. But big urethra, skin tube, causes some problem. It's a divertical occurs in the proximal junction. So always patient hold urine in the proximal divertical. But this is the easy. After urination, only compress the proximal divertical. So whole accumulated urine completely become empty. So at the beginning, patient complain. So underwear, become dirty. But this is not so serious problem. Also, urination, stream urination is also very difficult. How to make external ostium. This also needs a technique. So never close directly. Hinge flap is essential to get stream urination. Linear urination is very important. If urination or diversion occurs, the patient cannot urinate in the public toilet because his urination, disturb other, next person, So that's why stream urination is also very important. GLA patients always claim when I started penile reconstruction, diversion is a serious problem. So how to make smooth ostium, external ostium? This also we pay attention. Also strong urination, stream, powerful stream urination is also need a technique. External ostium become a little bit smaller, like fire car, fire hose. This portion become smaller. This is also very important point. If you make a big ostium, power of urination is weak, so cannot go distal portion, distal area. So strong urination, pressure of urination is also we always pay attention to such a small area, small portion.
Thank you, Professor, for nice discussion. My question is from Professor Newman. While planning the T-dep or tap flap,
Mm.
how do you do it? Do you do it retrograde or antigrade dissection? Like you find the perforator first and
Oh,
then go.
distal, from distal to proximal.
Yeah, that's right.
Yeah,
What Professor Koshima said. So we find first the perforator that's coming out from the muscle to the skin, and then we dissect proximally. But if difficult,
yeah. I never confirm the perforator because tap flap has very small capillary perforator in the proximal portion. So that I include intermuscular septum between LD and and yeah and which one serratus.
yeah. So
Cannot detect the dominant muscle perforator. So this is the complete different teed up. I always say top capillary perforator, top CP flap is completely different from standard teed up or muscle perforator flap. Muscle perforator base, top flap. This is completely capillary perforator flap, same as the skip flap. Skip also pedicle vessel is distal invisible perforator, just coming up the lateral border of sartorius muscle. Only this small capillary perforator. So that's why everybody hate to elevate this capillary perforator. So that's why skip flap always elevate distal and also proximal. Proximal portion also completely separate from the pedicle vessel. Only distal perforator area are preserved attachment. So that's why whole flap move to the genital region. Proximal dissection, complete dissection are necessary if you want to move the whole flap to the perineal region. Dual capillary perforator flap are necessary. This is a little bit terrible, but experienced person or working with me are no doubt to do such a dual perforator, capillary perforator.
yeah, I think already explained by Prof. Koshima.
Uh, Professor, we can use this step flap for lymphedema reconstruction as well, like if you want to do the vascularized lymphatic vessel transfer. So how do you plan that and how do you make sure that we avoid donor site morbidity of lymphedema
Hmm.
in the same limb?
Yeah. This this is also very interesting, also important question. Yeah, I always use lateral thoracic uh, system. So lateral thoracic area, many capillary lymph channel exist. That injection, we can detect the lymph channel, but this is very small, completely different from the web space flap. Web space, we can detect the lymph channel, but lateral thoracic area cannot detect in loops or even a microscope, the size of lymph channel is very, very small, probably capillary lymph channel. But with a dye injection, actually, we can detect small capillary lymphatic channel. And also, feeding vessel is not the thoracodorsal. This is the lateral thoracic system. So lateral thoracic system also had superficial, also deep system, deep branch, two branch. It's completely similar to the SCA system. So yeah, so this means both systems could be used, superficial and deep system. Also deep system, this portion to connect to the lateral intercostal perforator. So this is similar to the deep, yeah, SCI system. Distal portion of distal branch of deep SCI system connect to the perforator from the DCIA, deep circumflex iliac. Anyway, triple arterial system exists in the lateral thoracic area. This means that we can divide the lateral thoracic lymph channel a multiple portion. So we can get 4 or 5 lymph channel flap from the same area, lateral thoracic area. So bilateral very severe lymphoedema patient, we can transfer not only single, multiple lymph channel transfer possible. Thigh and lower leg and bilateral, and sometimes dorsal foot. One stage, multiple lymph channel transfer is possible. Someday, now I'm analyzing multiple lymph channel transfer from lateral thoracic area using deep and superficial lateral thoracic system, also lateral intercostal arterial system. So this is another next topic of lateral thoracic lymph channel transfer. Very severe bilateral lymphoedema patient. One stage, multiple lymph channel transfer is possible. How it works. Now I'm analyzed by AI. AI say this is very useful. So a selection of reconstructive method of lower leg lymphoedema is multi-site LVA. And if it doesn't work, next step is hemilateral lymph channel. In that case, contralateral normal web lymph channel transfer. But this is only one lymph channel transfer. If a bilateral very severe leg edema, those case against the multiple LVA, those case skip. If a skip region, skip area has no lymphoedema, in that case, skip lymph channel transfer is possible. Sometimes we can use 2 or 3 skip lymph channel transfer, 2 or 3 flap possible. But lateral thoracic area, some case also show very severe lymphoedema in bilateral growing region. In that case, we must use lateral thoracic area. So this area, many arterial systems, triple. So we can use multiple lymph channel transfer in one stage. So we have many options. Depend on the severity of lower leg edema, bilateral, very severe case, lateral thoracic, multiple lymph channel transfer. maybe next, a best choice. Yeah, probably, yeah. Who asked this question? Probably he is special lymphoedema, very severe lymphoedema.
Professor, actually, whenever we interact with you, we want to use the opportunity to learn about lymphedema as well. So that is why we are asking these questions. And these are very
Yeah,
precious. Actually, the answers are very precious.
yeah,
Uh, we can't find anything like this in the books. Most of whenever I interact with the people, the surgeons talking about lymphedema, they ask from where we should read it. My answer is usually that you should visit the legend himself, not the books. So they should come there to learn from you. So that is why whenever I interact with you, I come up with the idea that I should learn from you about lymphedema as well. So if there is any other question from the audience, then you guys
I
can
think
go ahead.
Sensei also, Mansoor, Sensei has to again be in one more. I think he should have a break. There is
Yeah,
immediately, so we do we conclude today, Mansoor, and we take a
yeah.
photograph.
One thing. My recent topic
Hmm.
is senile lymphoedema. I'm doing 80% of my patient surgery is senile lymphoedema. Every day I'm doing over 80-year-old or 70s. Very severe lymphedema patient, lower leg. But probably these patient had key point. Why lower leg edema is the patient occur? Probably amyloidosis related to senile lymphedema. And also probably primary lymphedema, young age. Some patient has amyloidosis. Recently, I'm suspecting. So next, this become a next big topic. Lymphedema caused by amyloidosis, congenital or hereditary or senile, acquired. It's become a very complicated etiology. So now I'm clearing this big mechanical etiology. Probably near future I'll open this new topic and concept. Today I first propose this amyloidosis and relation to the amyloidosis. Probably this also relate to the Alzheimer. Okay, yeah. We have many mystery and
okay.
interesting, point. Everybody who are, hearing this, my talk, probably advanced, microsurgeon. So everybody thinking, next, topic will be many things will be become a topic. Only you knows the future of lymphatic surgery, also microsurgery. Okay. Thank you very much.
Perfect.
Thank you.
So I think we are near to the conclusion because we don't have any more questions from the audience. Sachin, should we conclude the sessions?
Yes, please. We will also thank Mansoor, who accepted to be the moderator at a very short notice. And we would invite moderators and speakers from our group. And that's the reason I always ask for a short CV so that related to your interest in the field of plastic reconstructive surgery, we will call you upon. Thank you very much, Dr. Newman. It was wonderful to go through your journey of LDMC to TDAP flap. And as usual, Sensei, we can't thank you enough because each of your case is a thesis for us, all of us. Every of your documentation is so important for the present as well as the future generation of plastic surgeons. Thank you so much to all our members, and we see you not the next but the week after, that is 15th of November, because Sensei is having a conference to be attended in the next week. So we see you with the delegates from China, and thank you so much once again. Before we leave, we have our groupie. We please keep your videos on if possible to take the photo. Whoever can keep it on, we'll wait for a few seconds. Okay, ready? 1, 2, 3. Yeah. Thank you so much. Thank you, and Sensei
Yeah.
Mansoor, see you again.